Brilliant, as if by magic. In this session, we'll have an overview of Lewy body dementia and ways in improving diagnosis from Professor John O'Brien, followed by an interview with Chris Maddocks, a person living with Lewy body dementia and the ambassador of the Lewy Body Society. This will be followed by a Q&A session where we'll bring together these speakers, as well as Jacqui Cannon, the Chief Executive of the Lewy Body Society. And then finally, we'll be joined from Michigan by Dr. Jose Bras, an international expert in the genetics of Lewy body dementia. So to start, I'd like to introduce Professor John O'Brien. He is a professor of old age psychiatry at the University of Cambridge, and he is also a National Institute for Health Research Emeritus Senior Investigator and a Fellow of the UK Academy of Medical Sciences. He has long-standing interest in Lewy body dementia in relation to brain imaging and other biomarkers, diagnosis and management. He's been a member of the National Institute for Health and Clinical Excellence, NICE, the British Association of Psychopharmacology, European Federation of Neurological Sciences and European Stroke Association Dementia Guideline Groups. His other current goals are being a member of the Lewy Body Society Scientific Advisory Group, Chair of the Alzheimer's Society Research Strategy Council, and the NIHR National Specialty Lead for Dementia. So thank you so much, John, for agreeing to speak to us.
No, thank you. It's a real pleasure to be here. And thanks, Rimona, for that very kind introduction. Also to Claire, John Paul and the Lewy Body Society for the meeting. And I'd like to commend the Lewy Body Society, not only on their anniversary, 15 years, that's fantastic, but on all the great work that they do, both in terms of supporting people with Lewy body dementia and their carers, the advocacy work, and also the important work in terms of funding research, some of which you've heard about today. So I'm giving an overview on diagnosis and management, and we've always had some terminology difficulties in our field, and I'm going to use the terminology which I think we've now agreed and which the other presenters also use today, which is that when we use the term Lewy body dementia, we're talking about what we think of as a spectrum that includes really dementia with Lewy bodies, where the dementia presents first or within 1 year of motor features, or dementia in Parkinson's disease dementia, where people have established Parkinson's disease and motor symptoms for a year or more before they develop dementia. And we heard earlier there might not be a lot of distinction between those two, but clinically they do present in very different ways. We know it's a degenerative dementia that at its core is the deposition of synuclein, so it's a synucleinopathy. It has characteristic clinical features which we'll look at, and a variable degree of Alzheimer's pathology, again, as we heard from Tamarin earlier, particularly plaque pathology, but probably very few tangles. And we know that it's common. We say it's the second most common cause of degenerative dementia, but we don't know how frequently it's diagnosed in clinical practice. We know that pathologically we see changes of Lewy body dementia in about 15 to 20% of cases. It's age-related and it affects men slightly more than women. The core clinical features I think we're all familiar with, and we've heard about them already today. So we have cognitive impairment, of course. That's particularly affecting attention and visuospatial impairments. We have motor features of Parkinsonism, slowed gait, difficulty initiating movements, tremor, things like that. We have recurrent visual hallucinations that can be quite florid in form. We have fluctuation, marked variations in attention and alertness during the day. And we also have sleep disturbance, particularly REM sleep behavior disorder, this acting out of dreams when people are asleep due to loss of normal muscle atonia. So with features like that, one might think it's quite an easy disease to diagnose. These are very obvious features when you see them, but it's not an easy disease to diagnose, and that's for a number of reasons. One is that you don't always, of course, see all these features in every single person, certainly not at the early stages of the disease. There are also features that are seen in other disorders as well, so they aren't absolutely specific for Lewy body dementia. And also sometimes it's not quite clear if a symptom is really present or not. I mean, how much variation do you need to say someone fluctuates during the day, for example? How much slowness do you need to say someone has Parkinsonism? So these are difficult judgments to make. We can be helped by having indicative biomarkers. So these are investigations that can help. So there are 3 that we now recognize. One is reduced levels of dopamine transporter in the basal ganglia. So this is a change which we also see in Parkinson's disease. Another actually is a heart change on cardiac imaging, where we see denervation of the sympathetic nervous system. So this is also a reminder that Lewy body disease can start and certainly affects areas outside the brain, in this case, the heart. And also sleep studies, so polysomnography, confirmed REM sleep behavior disorder in a sleep lab. These will all add additional support to enable us to make the diagnosis. And we have diagnostic criteria, which have been revised a number of times, the most recent ones here from 4 years ago, where we have 4 core features and 3 indicative biomarkers. And these can be put together to make a case of either a probable DLB, where you have a fair degree of diagnostic certainty, or a possible DLB, where there's still a reasonable degree of diagnostic certainty, but there might be other causes for that dementia. So we know quite a lot about the diagnosis, and I wonder if that's why in the poll earlier, people gave diagnosis rather a low rating perhaps, and wanted to focus a little bit more on management. And I think it's important the two go together. But just in terms of diagnosis, because I think diagnosis is very important for people with Lewy body dementia and their carers, because it's often the gateway to access services and to understand the condition they have. Through the Diamond Lewy programme, we looked at diagnostic practice currently in routine NHS services in the UK. And we assessed a lot of people. This is consecutive patients being referred to services. This is not seeing people, this is looking at their case notes. So it was 10,000 people. And we asked the very simple question of how often is a diagnosis of Lewy body dementia made in people with dementia. And we found that of people with dementia, just under 5%, 4.6% were diagnosed with dementia with Lewy bodies. And we compared 2 parts of the UK. We compared East Anglia, and we also compared the northeast of England. And what we found is that there were different rates in these 2 regions. Rates are actually a lot higher in the northeast, in Newcastle, home, one might say, in the UK of dementia with Lewy bodies. And we were interested in reasons for that. Was that a true difference in prevalence, or were there differences in diagnostic practice? And although this observational study can't give us a definitive answer to that, when we looked at individual services, which are now shown in the slide below, I'll just try and get a laser pointer down here. If we look at variations between services, we actually see there's quite a lot of variation between services, both in East Anglia and the northeast. So you have areas in the northeast, services where rates are a little bit low, and you have services in East Anglia where rates are high. And these are services that are very similar in other ways, so we wouldn't expect differences in diagnostic rates. So it suggests there might be differences in diagnostic practice. This was looked into in a little bit more detail in some selective study of some of the Lewy body cases that is shown here. And what this shows is the number of clinical features people have to sort of meet the threshold for diagnosis. So this is all people here who've had a diagnosis clinically of Lewy body dementia. And here are people, they're diagnosed with Lewy body dementia, but they have fewer clinical features or indicative biomarkers than one would expect to be called a dementia with Lewy body's case. So in other words, they're a possible DLB case. And there are actually not many of them in either region, less than 1 in 5 possible cases. So given that we think there are quite a few possible cases out there from other studies, we're probably underdiagnosing possible DLB. The other thing is that we're not diagnosing some cases with DLB. So these are cases here that actually exceed the threshold for probable DLB. So they've got more than the core, 2 core symptoms or 2 core symptoms and 1 indicative biomarker. And you'll see here that certainly in the region where actually diagnostic rates were lower, they had the most symptoms in terms of exceeding the threshold before they were labelled a Lewy body case. So what that rather suggests is not only are we using the possible label relatively infrequently perhaps, that perhaps we're waiting slightly too long before we're labelling a case with dementia with Lewy bodies. We're waiting, in other words, until we're really, really certain. And that higher diagnostic threshold in East Anglia may be a reason for why fewer cases are actually diagnosed there in NHS practice. We also found, as others have suggested, that it's a more tricky and complex diagnosis to make. So, for example, time from referral to the diagnosis was significantly longer for dementia with Lewy bodies than for non-DLB dementia, that's usually Alzheimer's disease. It's almost twice as long, so quite striking really. It took almost a year to get a diagnosis after referral into secondary care if you had DLB, compared to non-DLB dementia. I mean, it was still almost 6 months in that case, but it's twice as long. And as a feature of that, and as part of that, the DLB cases had more clinical contacts, both prior to diagnosis and in total. And strikingly, and this is similar to a study that Jim Galvin did, a study of carers in the US, strikingly 51% of those eventually given a diagnosis of DLB had been given another diagnosis first, most commonly Alzheimer's or mixed dementia. So a lot of delays in diagnosis, a lot of misdiagnosis before making the sort of right diagnosis. So as part of the program we did, we tried to improve this. So my colleague Alan Thomas put together an assessment toolkit for dementia with Lewy bodies, which took validated questions from our group and from other groups to actually try and improve diagnostic rates, really by getting clinicians to think about the symptoms they would need to elicit and also how to elicit them. So there was a sort of reminder, this is really just a repeat of the DLB checklist. It's just reminding you what you need to have to fulfill criteria. But more importantly, it actually drilled down into validated simple questions compatible with clinical practice as to how you could elicit these. So for example, cognitive fluctuation. This is a validated scale taken from the fluctuation inventory described earlier. We can actually ask, does the patient show moderate changes in their level of functioning? Is it more difficult to arouse the person? Do they spend more than 1 hour sleeping? And sort of 2 or more on these 4 questions would be suggestive of marked fluctuation. And there's a question about REM sleep behavior disorder, which the Mayo Clinic validated. Has the person ever seemed to act out their dreams while sleeping, punch or flail their arms in the air, shout or scream? So this was a simple way of bringing these questions together and reminding us all really to ask about them in every case that we see with dementia, because these symptoms might not be apparent. And what we did was to go back and repeat the survey that we did of diagnostic practice after the introduction of these assessment toolkits. So this isn't a double-blind study, this is an open-label study where we looked at diagnostic practice of DLB and rates for 4.6%, and then we introduced the toolkit and went back 18 months later, and cases had increased significantly, actually to 6.2%. And that's quite striking, really. That's another third of diagnoses made over the baseline of DLB. So I think some demonstration it's possible to increase diagnostic rates. What's the point of that? Well, why should we want to diagnose DLB correctly? Well, partly because unfortunately, outcome in DLB we know is poor at the moment. So from several studies, we know that people with DLB have higher rates of hospitalization. They also have higher mortality. We also know they have poorer quality of life and poorer outcome from other measures. So they're going to need more support, they need more management. And we need to recognize cases so we can actually do the studies that will actually give us that evidence. So how might we improve outcomes? Well, I think the first thing to say is that outcome management in DLB is challenging. That's partly because there are multiple symptoms. People have cognitive impairments, neuropsychiatric features, the motor features, autonomic bladder and bowel problems, also sleep disturbances. So these are all complex areas. We know that treatments for one symptom may make others worse. The classic is giving L-DOPA for motor symptoms may make maybe some psychiatric features worse. Fluctuations can make treatment response sometimes difficult to assess. If you change the treatment with a person with dementia with Lewy bodies and they come back, they're slightly better, you think it's the treatment, but maybe it's a fluctuation. And similarly, if they're worse, you think the treatment's not working, but maybe actually it is working, but you're seeing them on a bad day. It can be difficult to prioritize different problems. And there's generally a limited evidence base, although it is fortunately growing. So the evidence base that existed was used together with an expert international panel that was put together by John Paul Taylor and Ian McKeith to develop the Diamond Lewy Management Toolkit. So what this really does is take what we thought was best evidence-based practice and what we know about how to manage these different symptoms in people with Lewy body dementia. And this is now looking at DLB and PDD and putting them together in a single toolkit that's helpful for clinicians to be able to use in the clinic when they're seeing people with Lewy body dementia. And this was divided into symptoms under the different domains. I think these 5 domains are very helpful. The ones I went through before: cognitive, neuropsychiatric, sleep, autonomic and motor, not least because they remind us that these are the clinical features we need to ask about to see if there are particular problems. Now, having developed this toolkit, we then put it into a randomized cluster trial. Now, Eli Matos described some of the trial and the results, so I'm not going to talk about that very much. This wasn't really an efficacy trial of the toolkit. This was a feasibility trial. Could we introduce the toolkit into services in the NHS? Could we get clinicians to use it? And did we find that there might be any benefits? And we were able to introduce the toolkit into services. Clinicians rated the toolkit very highly on the kind of qualitative work that we did. And in terms of some of the benefits, we did find that people in the toolkit arm did show some improvements in terms of how they're rated globally by the carer, and also in some carer outcomes, as I think you heard earlier, in terms of carer reduced depression and reduced burden. So some evidence putting current practice in can be done in current NHS services and may have some benefits. Can we move beyond that? Well, we've heard a lot today in terms of the future research landscape. We've heard of lots of potential disease mechanisms, modifying alpha-synuclein, modifying inflammation. Amyloid is very much in the news with the Biogen aducanumab FDA decision. There are lots of potential mechanisms that might not be the core ones in dementia with Lewy bodies, but possibly modifying them might be helpful. And we are now having some studies. This is a phase 2 study which reported a conference last year of a compound, Inflamipod, which is a protein kinase inhibitor. It has a number of actions, including on inflammatory pathways and tau and some other areas as well. But very promisingly, I would say, although one never knows if these findings will translate to further stage studies. In a phase 2 study of 91 people with DLB, the high dose of this particular compound did have some benefits in terms of cognitive outcome compared to low dose and placebo. So I think there are things, and there are other compounds that are coming through. So just to wrap up, I think DLB is important to diagnose because the management is different. We should think as clinicians about DLB when we're diagnosing or reviewing people with dementia in case they've developed new symptoms, and we should ask about some of these core symptoms. If we're not sure, there are indicative biomarkers that can help us support or refute the diagnosis. In terms of management, we should take a holistic approach and think about all the domains that I've talked about. Cholinesterase inhibitors are the one drug class that really should be offered. There's very good evidence base for their impact on cognitive and also some non-cognitive symptoms. But don't forget to ask about other symptoms, which may actually be much more problematic for people with DLB and their carers. And I'd just like to thank everybody who's been involved, not only in the Diamond Lewis study, but also within our ongoing work in the Cambridge Centre for Parkinson's Plus. Thanks very much. I'll just stop sharing now.
Thank you very much. That was absolutely brilliant. Such a clear overview of dementia with Lewy bodies, and very helpful to hear how the work that you've done and really improving sort of our diagnostic accuracy. Also some hope there that there's some new treatments on the horizon, and that potentially could be changing treatments, changing outcomes. So some sort of exciting things coming up. We've already got some questions in the chat, but what we'll do is we're going to move to Rachel and Chris, and then we'll do a Q&A session with everybody together. And I'm absolutely delighted to introduce both Rachel and Chris Maddocks. Rachel is the Consultant Admiral Nurse for Lewy Body Dementia, and she's funded by the Lewy Body Society. So it's absolutely wonderful that she's joined us today. It's a national role offering education, consultancy, and direct clinical support for families. Rachel has worked as a nurse for over 30 years across a range of settings, and first specialised in dementia care as an Admiral Nurse in 1999. And she's going to be speaking today with Chris Maddocks. So Chris worked as a police officer for 30 years, but in July 2016, at the age of just 60, she was diagnosed with vascular dementia following 3 minor strokes. In 2018, she was diagnosed with Parkinson's disease, and then subsequently in January 2020 with Lewy body dementia. She now lives in Eastbourne with her partner and is an active campaigner for people with dementia. She's a member of the 3 Nations Dementia Working Group, an active participant of the DEEP network, and is an ambassador for both the Alzheimer's Society and the Lewy Body Society. Thank you both for speaking with us today.
Hi, my name is Rachel Thompson. I'm the Consultant Admiral Nurse for Lewy Body Dementia, working with Dementia UK, and delighted to join you today for the Lewy Body UK Conference. I'd like to introduce you to Chris Maddocks. You want to say hello?
Hi, my name is Chris. I'm from Wales. I'm now living in Eastbourne, and I'm a retired, well, I was a police officer for 30 years.
Thank you, Chris. So we're joining you today for a session around thinking about the lived experience of Lewy body dementia. And Chris has a diagnosis of Lewy body dementia, and I'm going to invite Chris to answer a few questions. So Chris, to start with, can you just tell us a little bit about your diagnosis and how you got it?
Yeah. Just to go back to the beginning, I was diagnosed in July 2016 with early onset vascular dementia when I was 60. I moved from Cardiff to Eastbourne in 2017 because I was struggling on my own. Diagnosed with Parkinson's disease in 2018, and then in January of last year, I was diagnosed with dementia with Lewy body. And the reason that I got diagnosed with that last year is that I'd been living in Eastbourne for 3 years, but I'd never been under a neurologist, or I hadn't been under anybody. And my GP said, well, we're not specialists in dementia. So in fact, it was my Parkinson's nurse that was managing my dementia. And not only that, I still drive, but I have to reapply for my driving license every 12 months. And my Parkinson's nurse used to say, yes, you know, in my opinion, she's still fit to drive. And then the DVLA and the Department of Work and Pensions changed it and would no longer accept reports from specialist nurses. It had to be from consultants, which I think is ridiculous because I didn't have a consultant. So yes, I waited 3 years before I had an appointment, and I knew that I had some symptoms that were changing and new symptoms that were coming.
So you mentioned new symptoms. What kind of symptoms did you have?
I'd lost my sense of taste and smell, which I hadn't put down to dementia, but I now know that it's linked to Lewy body dementia. Lacking some spatial awareness when I'm walking around and always banging into doors, and I'm always covered in bruises. And restless and painful legs. And I mean, when I say painful, they're really painful, and it's always in the early evening and at night time. Difficulty to getting to sleep at night and staying asleep. And I get an average about 4 hours sleep a night, which is, I know, probably not enough. Lack of energy. I had anxiety and low mood, some balance issues, changes cognitively, and I felt I was becoming more forgetful. I also have some swallowing difficulties. There's certain foods that I find difficult to swallow. Little interest in doing things, and I have found it difficult concentrating and staying focused.
So, Chris, what was it like getting your diagnosis of Lewy body dementia?
It wasn't good, because I thought when I went to see the consultant, they had done I think it was an MRI scan, and I was just expecting to be told about the changes, you know, in the brain from the scan. And she did say to me that there were changes in the brain stem, but didn't tell me what the changes were. And I told her about my symptoms, and she gave me a physical examination. And I really wasn't expecting to get a new diagnosis. So she said, you've possibly got Lewy body dementia. And when I said, well, do I have it or don't I have it? She said, well, you possibly got it. She said, and it can only be confirmed on autopsy. And I thought, I'm not ready for that yet. So I left there with no information, no sort of signposting to anywhere, you know, no further appointments. She was discharging me. So I felt really, I felt as I did when I had my first diagnosis, and that was, it left me feeling useless, and it left me feeling hopeless, and it knocked my confidence as well. And I thought, well, I've got loads of questions. Who do I turn to ask these questions? So I was disappointed that there was no sort of signposting. And, you know, if you suffer with cancer or a heart condition, there's a clinical pathway, but we all know with dementia that there isn't one. And you're lucky if you're handed a leaflet, but I wasn't even given a leaflet to read. So it was quite devastating to me.
Mm-hmm. So, Chris, a couple of years on, and you are keeping well as you can, and you're very involved in both being an ambassador for Lewy Body Society as well as the Alzheimer's Society. What would you say keeps you well?
I would describe myself as a dementia activist, because I think there's so much ignorance still about dementia. And I found not just members of the public, but sometimes in the medical health profession as well. So I just want to raise awareness. And when I was first diagnosed back in 2016, I also lost my job within 3 months of getting my diagnosis. And we all need a purpose in life. We all need something to get up for in the morning and to look forward to doing. So I do lots of talks, mostly via Zoom. I do find it more difficult concentrating on the telephone now. It's much better when I can see people. So I give lots of talks. I belong to a couple of peer support groups that we've set up ourselves, really. I managed to set up in Eastbourne a peer support group for people living with dementia, because there are no services at all in Eastbourne where I live. There were, but the council made funding cuts, and now there's nothing. And also, I feel strongly about this postcode lottery. In some areas you get help, in other areas that you don't. So I'm trying to make it my business to do what I can, and do what I can whilst I can. So, and I think because I'm using my brain, and I'm talking and I'm writing talks and things like that, it's keeping me busy. And it's I find days when I haven't got anything to do, my dementia symptoms are worse, because, you know, just sat down or doing things. So yeah, it keeps me more focused by doing things, certainly. And also I'm doing something at the moment. It's called Living Well in Nature, I think it's called. And once a week I go into the woods, and we've got a woodsman and a cook. And we spend 2 hours in the woods, sat on benches, and we have a fire, and we're given knives to whittle with. Now, who'd give a person with dementia a knife? We light fires and things like that, and it's one of the best things that I've done, because I think we need things to look forward to. We need things to enjoy doing. And recently I've signed up for a few research things as well, because I think it's important for people living with dementia to be involved in research. Hugely important.
So, as you mentioned about research, for people who are listening to you now, what advice would you give them if they're planning to do some research with people with Lewy body dementia?
I am involved in a few PPI groups and some research. And I think one of the most important things is to involve people living with dementia right at the beginning of your research, from the onset. And what I've found is some of the things I've been involved with, they only involve people with lived experience towards the end of their research project. And then they realise things that they hadn't realised before, whereas had we been involved from the beginning, then we could have had more of an input. And I've had people say to me, oh crumbs, we never even thought about that. So with the lived experience, you get the lived experiences. And the other thing that's very important to me is for people to talk clearly and not to talk too quickly, because I think the best way to describe it, and you probably all know this anyway, is that I can process things, but I can't process them very quickly. And I find if people are speaking quickly to me, sometimes I don't hear anything that they're saying.
So Chris, I think there's opportunity for people to ask us some questions, so I'm going to finish it there, but thank you ever so much for sharing your experience.
Thank you for the opportunity.
Thank you so much to both of you, and particularly to Chris for sharing your experience, exactly as Rachel has said, and such a useful and important lesson for all of us to involve people with Lewy body dementia in the early stages of planning any studies that we're doing. So what I'd like to do is invite back to our panel. So John O'Brien, thank you for joining back again, and Rachel and Chris, lovely to see you, and Jacqui, brilliant. So we've got some interesting questions. So I'm going to start with John, if that's all right. So a theme that's come out, particularly in this session, is how long it can take to for people to reach a diagnosis. So I'll kind of join together a couple of questions, but one of them is, how aware are people, other primary care providers such as GPs, about Lewy body dementia? And is there a way that we can work perhaps in a more joined up way, or perhaps even roll out something like the Lewy Body Toolkit into more memory services around the UK?
Yeah, thanks. It's a great question. I think it's very variable, to be honest, but I don't think levels of awareness are high in primary care. And I saw that question from Kerry. I assume you're a GP, and it'd be interesting to know your thoughts. But my general impression is really GPs have a really tough job at the moment. You know, they've got to be experts in all sorts of things. And I think our job in secondary care is to help signpost and sort of support the diagnosis. So I suppose I'm saying that because I never really expect the diagnosis to be made in primary care. You know, I think it's a specialist diagnosis, a secondary care diagnosis. It's a complicated diagnosis, and you want it to be as accurate as it can be, given all the uncertainties that we know, even in currently secondary care. So I think primary care should be a place where there's an awareness of what symptoms might mean and signposting. When we originally conceived our programme, we actually wondered whether to place this in primary care or secondary care. But although one might think that we all, and I count myself in this because I run memory clinics, we all forget to ask about some of these questions. We sometimes realise when we're driving home after the clinic that maybe that person had Lewy body dementia, or same applies to frontotemporal or other dementias. I think there was a clear need for awareness raising and toolkits there first. I think having done that, and I know there's a sort of question about rolling it out, which is also very important. Having done that, I would really like to move this on into primary care, and maybe through the Lewy Body Society, another forum, we could start to do that. Not to say use these toolkits, use this, but simply to say, you know, these are some of the key symptoms that might illustrate Lewy body dementia.
Brilliant, thank you. And another question, I'm actually going to ask both John and Jacqui this question, because I'm quite interested in your sort of different perspectives. We've had a great question asking about plans for non-pharmacological treatments and whether there are any trials planned for that. And what the reason I want to ask both of you is because you're kind of from the perspective of sort of clinician researcher and then also sort of funder. So I'm interested to know what each of you think. So maybe Jacqui, what are your thoughts about that?
Yeah, really interesting question. As I said in my opening comments, that we will be having another grant round in early 2022, and we would welcome any grant applications for those types of research. You know, we've funded in the past carers groups, and would love to just look at anything that would make the lived experience of the person living with Lewy body dementia the best it can be. So yeah, we are definitely open to looking at those type of applications.
Thank you. And John?
Yes, well, you're absolutely right. There isn't much out there. There have been a couple of good systematic reviews of non-pharmacological treatment of dementia with Lewy bodies, and both found really very little in terms of high quality studies. There are some studies, interestingly, of using thickened liquids to help with swallowing, quite a good study of that. There are also some interesting case reports ranging from all sorts of things, from sort of exercise and social stimulation and other things, but it's very hard to build an evidence base on that when it's just a few cases. So there's a clear need for it. I would encourage people to think about those studies because they're incredibly important, and they've been very important in Alzheimer's disease. Let's remember that in Alzheimer's disease, there are only really two nice recommended therapies: cholinesterase inhibitors and cognitive stimulation therapy. And so I think there's plenty of reason why we would be interested in non-pharmacological interventions in DLB. The only other thing I'd say is that I am now starting to become involved in some discussions with people who are interested in looking at some of these other interventions, and I think that's very positive. So I would encourage more in this space, definitely.
Brilliant, thank you. Totally agree that we need to think more widely and broadly to see anything that we can do that can change outcomes. It's a really interesting question that I'm going to ask Rachel and also John. So this is somebody's asked, my mum has early stages of Lewy body dementia and she's on medication which appears to be helping her symptoms so far. In your view, what things or medications do you feel has the most benefit for an LBD sufferer's short-term and long-term symptoms? So perhaps Rachel, from your experience, and then if you don't feel like we're asking you too much, then I'd also like to hear from John.
Yeah, so thank you for the question. I get a lot of questions like this from families I'm supporting on our helpline. I think what we find is the cholinesterase inhibitors, as John has referred to, are usually the starting point. Occasionally, some people don't tolerate those, so we need to think about perhaps things like memantine. But I often say it's about looking at the person's symptoms and balancing that with what their quality of life, what are the symptoms that are the problem for the person, and then trying to adjust things, whether that be through medication, but also looking at, I think as has been really importantly raised, the non-pharmacological support, the social support that Chris importantly talked about, the things that keep people as active and as engaged as possible. So I think there are lots we can learn from other areas, so from other types of dementia, what interventions seem to be working. Increasingly things like exercise may need to be modified, social engagement, peer support for both the person with dementia but also for their family carers as well, because, and I often talk about it being people being a whole system, that actually particularly when you've got people who are living with somebody, but even when they're not, what affects the person with dementia affects the family as well. So both need supporting. Don't know if you've got anything to add to that, John.
Rachel, I thought your answer was brilliant. I'm not going to repeat anything because there's no point. All I would say is what I emphasize with people is to maintain function by doing the activities they like. And I think that's really important because sometimes people think they should, take up marathon running when they've never run before because exercise is good. I mean, you've got to do things that you enjoy doing and that improve your quality of life. So do things that you enjoy. And in relation to the other treatments that are available, it depends very much on the individual. No two people are the same. And so it's back to that inquiry, or people who have dementia with Lewy bodies themselves and their carers thinking, well, do they have problems with motor symptoms and Parkinsonism? Do they have autonomic symptoms? And then it would be management very much directed at that rather than this tablet everybody with early DLB should be on.
Absolutely. Brilliant. Thank you. Both excellent answers, really helpful. Chris has made a comment in the chat, which I think is so insightful. I don't know if you wanted to sort of vocalize, say that comment about your journey, how difficult it was to get to a diagnosis.
Yes, thank you. I was living in Wales when I was first diagnosed with vascular dementia in 2016, and I moved to Eastbourne in 2017. And apart from the Parkinson's nurse picking up, because I was diagnosed with vascular Parkinsonism, not Parkinson's disease, and the Parkinson's nurse picked up on the letter and arranged to see me. But the memory services didn't want to see me, and neither did anybody really, because I'd already had my diagnosis in Wales. And had I not kept pushing and asking to see a neurologist, I would never have had my dementia with Lewy body diagnosis. And I don't know what else we can do. I just kept insisting I needed to see somebody. And this seems to be a big glitch on the postcode lottery thing again.
Thanks, Chris. I've got one last question that I'll ask you, but we'll see if I might have time to maybe ask Jacqui, which is, of all the talks that we've seen this morning, is there anything that you've found to be interesting or sort of perhaps exciting at all? And perhaps, Chris, if you're happy to answer that, or if you want to take a minute, I can ask Jacqui first.
To be honest, a lot of the talks were a little bit over my head, but
enough.
I would just say that I think that you're all doing remarkable work, and if I can help in any way, shape or form to improve anything for people living with Lewy body dementia, I'm more than happy, and I'll give talks. I don't mind being a guinea pig, so if you want me, I'm here.
Wonderful, thank you. And Jacqui, is there anything that you've heard this morning that makes you think, oh, that could be interesting?
Yeah, I think every single speaker that I've heard, and I'm not just being kind with those comments, because I think every single piece of research that is taking place for Lewy body dementia, as you said in my bio, that my dad had Lewy body dementia. He was on absolutely no medication because of the underlying medical problems. He couldn't tolerate anything. So any research whatsoever for me is just kind of pure gold. And every time I hear somebody speaking about a research project that's just starting or well underway is just really, really good news.
Wonderful, thank you. Thank you for being so positive about everybody. So there are still some questions, and I'm so pleased that people are interested and want to ask the questions. We're going to have to move on to the last session, but perhaps if some of the panelists might answer some of those questions in the